Welcome to JACC This Week. I'm Harlan Krumholz, Editor-in-Chief of JACC, and this is our issue for September 9th, 2025. This week we cover artificial intelligence in cardiovascular research, new insights on tirzepatide and heart failure, the influence of social and racial factors on heart failure risk, genetics in atrial fibrillation, and the growing burden of heart failure in the oldest old. We also feature an Amara Yad anatomical contribution and important perspectives on clinical trial design, and more. Let's start with the editor's page. We have an editor's page that was led by Sneha Jain from Stanford and many of our consultants in artificial intelligence. What we wanted to do was to provide some guidance to people who wanted to submit articles to us in the area of artificial intelligence and cardiovascular disease. We've been receiving more of these submissions, and we felt that there was a need to lay out our strategy. What is it we're exactly looking for in these AI research contributions, especially as the field is moving so fast? In this piece, we describe a continuum of AI research, from stage 1, early model development and validation, to stage 2, implementation in real-world settings, stage 3, broader deployment and evaluation, and stage 4, long-term monitoring and iterative updates. We emphasize that there are 3 domains that JACC will focus on: methodological rigor, real-world feasibility, and plans for long-term monitoring. Look, there's so much out there in the world. What we're trying to say is that what we want is submissions that help our readers understand artificial intelligence, demonstrate exactly what it can do and for whom, lay the groundwork for strong evidence about it, either in its development or in its evaluation, and ultimately to help advance cardiovascular health. In the piece, we say a JACC-worthy AI manuscript demonstrates not only technical excellence, but also high clinical relevance, deployment feasibility, and a clear path to improving cardiovascular care. We're setting the bar pretty high, but we think that's where it needs to be. So let's move to the original research. I want to start with a paper, Tirzepatide in Heart Failure with Preserved Ejection Fraction and Diabetes, by Packer et al., leveraging data from the SUMMIT trial. These authors ask whether type 2 diabetes influences the clinical benefits of tirzepatide in patients with heart failure with preserved ejection fraction and obesity. And just as a little promotion, I also did the JACC deep dive this week on this paper. I went a little deeper than you're going to hear right now and laid out some of the issues that were discussed internally. But here, let me just get to the high points. We know that diabetes attenuates the weight loss from incretin drugs. I'm talking about the drugs like GLP-1 receptor agonists and the combination drugs. And in the SUMMIT trial, patients with diabetes did lose less weight than those without. Remember, SUMMIT was a study of people with heart failure and preserved ejection fraction, testing whether tirzepatide would improve outcomes, and it did. Now, in this sub-study, importantly, those with diabetes had a similar decrease in the risk of heart failure outcomes, and interestingly, a similar decrease in pericardiac adipose tissue. So again, less weight loss, but a similar decrease in the pericardiovascular adipose tissue and a similar decrease in the risk of cardiovascular outcomes. The authors conclude that despite less pronounced weight loss, patients with HFpEF, obesity, and type 2 diabetes responded favorably to tirzepatide with reduced cardiovascular events, improved quality of life and exercise tolerance, and decreased LV mass and pericardiac fat. The editorial by Savarese and Butler asks, how can outcomes be similar despite differential weight loss? They point to consistent reductions in left ventricular mass and pericardiac fat across groups. The message is that benefit may extend beyond weight loss, perhaps through direct cardiac and metabolic effects. I'm sure there's going to be a lot more on this, and this sort of disconnect between the amount of weight loss and the amount of benefit raises this question of how exactly is this benefit mediated, since it may not all be about weight loss. Next is a study, Racial and Ethnic Differences in Age at First Heart Failure Hospitalization by Huang et al. And I first encountered this study at the ACC, where it was in the Young Investigators Investigation. And this one got a lot of attention, and the team did a great job. And we were very happy when they submitted it to JACC, and we're happy to accept it and publish it. So in this one, Huang and colleagues are using the Get With the Guidelines Heart Failure Registry and examining the experience of more than 42,000 adults across 713 hospitals. They found that Black and Hispanic patients experienced their first heart failure hospitalization at much earlier ages than white patients, with a gap as wide as 13.5 years. These differences were strongly associated with social risk factors, including unemployment and access to public insurance. The accompanying editorial makes the point plainly. Quote, "To achieve equitable outcomes in heart failure care, we must identify, assess, and address the socioeconomic, structural, environmental, and psychosocial factors that contribute to increasing cardiovascular mortality and morbidity." This is a reminder that heart failure is not only a biological condition, but one deeply shaped by society. And the reason we at JACC were interested in this paper is because it had a large number of people, and they really showed in bright relief that characteristics that are really not biological, like race, are strongly associated with when people were first hospitalized with heart failure, leading us to try to investigate, well, how is that mediated? What are the issues? And how do we prevent it? In another study, incidence of heart failure in Asian Americans, Native Hawaiian, and Pacific Island populations by Ambrosi and colleagues. So Andrew Ambrosi and colleagues looked at over 2.6 million adults in Kaiser Permanente. I think what was interesting about this is that there are usually very few Asian Americans, Native Hawaiian, Pacific Island populations in studies, or at least they're not identified very clearly, and they're all lumped together often. And so in this study, they disaggregated the Asian American, Native Hawaiian, and Pacific Island population, and they found substantial differences in their experience. Most groups, Chinese, Japanese, Korean, Vietnamese, had a lower risk of incident heart failure compared with white patients. But Native Hawaiian, Pacific Islanders, and South Asians had significantly higher risk. And this was driven particularly by HFpEF. The editorial puts it well that this population, this Asian American, Native Hawaiian, and Pacific Islander population is not a monolith. Disaggregation is critical given the substantial variation in cardiovascular risk in treatment response among subgroups. Look, it's been too long that we've taken a group that actually is the majority of the world's population. Asia contains the majority of the world's population. And what we've generally just said is Asian Americans, rather than appreciating that there are cultural, contextual, and more differences among various different groups. And if we really want to learn about it, we have to disaggregate it. This study really shows the problems with lumping together a heterogeneous population and missing important clinical differences. The next study focuses on pathologic cardiomyopathy variants in atrial fibrillation by Ruff et al. So Christian Ruff and colleagues, working with the TIMI study group, analyzed genetic data for more than 18,000 patients with atrial fibrillation in large clinical trials. With a replication in East AFNET4, they found that 2.4% carried a rare pathologic variance in cardiomyopathy genes. These patients had a higher odds of prevalent heart failure, more heart failure hospitalizations, and higher cardiovascular mortality, particularly those with dilated cardiomyopathy variants. But interestingly, there was no association with ischemic stroke. And the idea was this was likely because of anticoagulant use. That is, actually these patients were being treated. So again, 18,000 patients with atrial fibrillation from these large trials. They're looking for pathologic variants in cardiomyopathy genes. 2.4% have it. These all have a higher odds of prevalent HF and hospitalizations, but not ischemic stroke. Interesting. The editorial notes rare cardiomyopathy-associated variants confer important prognostic information in patients with AF. This opens the door to genetic testing, informing prognosis even in older comorbid populations like those with atrial fibrillation. And I guess the question will be, are we going to start doing this? Will it change our practice? Will it have important implications for patients? And ultimately, will it improve outcomes? But this study is at least showing that there are factors that we usually are not measuring that may be important, even if in this study it was in a small minority. So we have a brief report from Japan looking at heart failure in the oldest old by Kitai et al. So this group analyzed nearly 740,000 hospitalizations between 2016 and 2022. They found that patients greater than or equal to 85 years old now account for, wait for it, believe it or not, 45% of heart failure hospitalizations in Japan. and about 45% of inpatient costs in Japan. I'm going to say this again because this is amazing that in Japan, those 85 and older account for 45% of the hospitalizations, 45% of all inpatient costs. So despite having the lowest per episode costs among people of various ages, the sheer growth of this population is driving the burden. And we often think of Japan maybe as ahead of the curve of us. That is, they've had an aging population for a while. And by the way, they've got a really great life expectancy, so that's good, better than ours in the United States, maybe one of the best in the world. But that population is growing just like it's growing everywhere. And now they're beginning to show us what the consequences of that are going to be. Home discharge, by the way, decreased while transfers to care facilities increased with this growing age, underscoring the growing demand for long-term care. This is really setting the stage for, I think, what we're going to be seeing in all aging societies. The issue also has an MRI image. I really recommend if you can get a chance to take a look at these. They're really striking. This one this week is on the interior of the right atrium and left ventricle, and it highlights septal structures and their implications for transseptal access and left-sided procedures. And just as a reminder, these are really about producing resources that are an ethical alternative to the infamous Perkoff Atlas, which was using victims of the Nazis to develop images that were used to treat medical students for a long time. And this is meant to supersede that. In a piece from JACC BTS, Mann and colleagues discussed de-risking phase 2 heart failure trials. They call for smarter designs using biomarkers, recurrent events, adaptive methods, and enrichment strategies to make drug development more efficient and more predictive of phase 3 success. The idea is there are a lot of phase 2 trials that look very promising, and they just fail in phase 3. And Mann and colleagues are trying to unravel the mystery here. Why is this happening? What can we do better? How will this work? The issue also has some clinical cases, one on obstructive hypertrophic cardiomyopathy with concomitant aortic stenosis in high surgical risk patients, another one on hydroxychloroquine cardiotoxicity, overlapping with sarcomeric hypertrophic cardiomyopathy. Both remind us of the complexity of real-world presentations and the need for careful diagnosis. We also have some other things from the other family of JACC journals. What we're doing now is running these articles in main JACC in the print version and wrapping them into an issue so that we can make sure that people see the great stuff that's appearing across the entire JACC portfolio of issues. So what did we learn this week? Well, first, AI research in cardiology, to be actually merit publication in the best places, must go beyond algorithms to address clinical feasibility, utility, long-term safety. 2, tirzepatide benefits patients with HFpEF regardless of their diabetes status, though the results of the study that we presented today shows this really interesting discordance between weight loss and some of the benefit, in the sense that the weight loss doesn't explain everything that's going on here. And it's opening up, I think, a dialogue about exactly how are these drugs working. And for the part that's not tracking with the weight loss, how can we understand it? We also learned about social and racial disparities profoundly influencing when patients first encounter heart failure. We learned that Asian American Pacific Islander subgroups face very different groups when you disaggregate, really look at individual groups. And so really the lesson here is disaggregation of these groups is essential if we're to learn more about them. We learned that genetic variants in patients with atrial fibrillation confer a risk of heart failure and death, but not stroke. And it's really opening this question about whether we should start using these genetic markers as part of our prognostic workup, our prediction of what's going to happen. But it's going to be a question of whether we can link that to actions that actually improve patient outcomes. Next, we learned that the oldest old are now at the epicenter of heart failure hospitalizations in Japan, maybe giving us a warning that in all aging societies, this is the direction that we're headed. And then there were a variety of pieces from the other JACC journals, but the one that I just wanted to call out in particular is about this smarter trial designs may help us avoid repeating past failures in heart failure drug development. So that's it for JACC this week. I hope you've enjoyed the show, and I hope you enjoy the issue. I'm Harlan Krumholz. Until next time, stay curious.